Now I am in Stockholm, Sweden. Today I was with Dr. Par Hidin. He's a legendary cosmetic surgeon. So today I see in a atypical case. This is not a very routine thing in every practice. So I thought I should describe what I have seen, and this will help in two ways. Uh, for me, I can recapitulate so that I can remember it better, and for other people who are seeing this talk or video, they can also get the conception. So so the surgery was a around 32 years female patient. She was having two child, but the problem which she was having, breast problem. She has tuberous breast deformity, but the tuberous breast deformity, and also because she has breastfeeding, she has sagginess of the breast, and also there was less amount of volume, also breast volume was also very less. So I think, and this tuberous breast was not very severe. This is definitely not very severe kind of tuberous breast deformity. There are classification of tuberous breast deformity, but I think this is not a severe case, but definitely it was a tuberous breast. So in severe case of tuberous breast deformity, their mastopexy has to be done, and some kind of skin expansion has to be done by adding some skin tissue by different techniques. But as it was not a severe type of tuberous breast deformity, Dr. Parhidin planned augmentation and also fat grafting. So what the main problem is, tuberous breast deformity, with tuberous breast deformity, the lower pole is not very much well formed. There is lower pole tissue defect or tissue deficit, especially lower pole tissue deficit. So if I so the breast, it has lower pole deficit in the lower part. So the inferior mammary crease is very near to the nipple areola complex. So we have to expand this inferior pole. So we have to expand this inferior pole. So what he said, during the marking, patient will be in standing position. And 45 degree. Her hand should be elevated. This is 90 degree, 45 degree. So when you elevate the hand 45 degree, that there is always the nipple areola complex move little bit with the movement of the hand. If you get the full extension, the nipple areola will come upwards. 90 degree it will be middle, then you down, it will further down. So you have to keep in 45 degree. So in this 45 degree, you mark the original inferior breast border, and you mark the base diameter of the implant. So half of the base diameter from the nipple you have to mark. So we have seen in this case, the base, if we measure the base diameter, half of the base diameter from the nipple areola complex, it goes around 3 centimeter below. So the original inframammary crease has to be low down at least 3 centimeter, so that the breast implant get positioned behind the nipple areola complex, centralized behind the nipple areola complex. Because if you use the original inframammary crease, then the implant is going to be higher placed, so it will give a artificial look, or it will give a bad look. So in this type of cases, and also in transgender patients who are male to female breast augmentation we do, in these cases also we have to treat cases as tuberous breast deformity. So the inferior mammary crease, you have to, how much you will go, where you will give the incisions. The incision will be from the 45 degree extension of the hand, and at that position you go half of the base diameter of the implant. So that will be the incision mark. So there will be the neo inferior border of the breast. So this is how the marking was done. Patient was done under general anesthesia, and usually we in the operation table hand is extend, but in this case hand was kept side by side. So in the marking area he did the incision and processed, and especially you can see in this tuberous breast deformity the pectoralis major muscle is positioned quite high. In this patient it was almost in the original patient's nipple areola position. So we have to go basically we dissected under the fascia in the chest fascia, chest deep fascia. So we actually dissected the chest wall, and this chest wall will become the new breast inferior pole. Then we get the insertion, high insertion of the pectoralis major muscle, and also we can see abnormal blood supplies of these muscles, because we can see brisk bleeding from one or two arteries, and usually in this area in the middle area we didn't get this type of bleeding. So the dissection was done, and then he did 245 cc breast implant insertion. So it looked nice, but what happened after before this breast implant insertion he did fat augmentation of the lower pole, because the lower pole skin thickness was thin, so he wanted to give more volume in the lower pole. So in both side he has given 90 and 90 cc fat injection in the breast tissue, in the chest wall tissue, which is going to be the breast inferior pole of the breast. So before insertion of the implant he did this fast augmentation around 20 ml in the 20 to 25 ml around this cleavage area, and rest in the inferior pole. Then he did insert the implant with Kilner funnel. So after insertion of the implant we can notice that the original IMF was looking like a band or like a depression. So new nipple area, new inferior crease has been formed above 3 cm. There was the original one, so it was looking like a depression. So I was thinking how he is going to manage this depression, how he will score the tissue to release, and I see he used Gillies forceps, Gillies hook, skin hook. He just anchored the tissue, the skin, and with a needle, 14 gauge needle, he just do the subcision type of thing. He do subcision, and after subcision I was very much amazed to see that almost 90% of the depression of the original IMF fold has been gone. So he did this type of subcision. He just hooked with a Gillies hook and then did the subcision by the needle. So it was a very nice thing to see. Then another thing I have seen that the nipple areola complex was very much puffy and it was just poking out. So it was looking typically abnormal. Typically just it happens even when I did cases of breast augmentation, especially for this type of patient. This also happened, but I didn't know how to manage this nipple areola complex which is popping out. So he did around 10 stabs in the nipple areola complex, and using the electrocautery, he inserted the electrocautery through the stabs. He makes stabs around this nipple areola complex, and within the stab he inserted the electrocautery and just cauterized the areolar tissue, sub-areolar tissue, and the areola comes down. So it was very nice thing to see that how beautifully it's come down. When he did completed the right side, and we can see the clear difference. Nipple areola complex, one side is popping out, another side is quietly well settled. So this is also new thing I have seen. So in this surgery I have seen a moderate tuberous breast deformity surgery. To summarize, this was a moderate tuberous breast summarize. It is a moderate tuberous breast deformity. So he used new nipple areola, new inferior breast crease marking from the nipple areola to the half of the base distance, base diameter of the implant. There he marked the incision. And secondly, he did fat augmentation of the lower pole and on the medial cleavage area. Third, he did subcision by skin hooks and by the needles. This is the third thing. And fourth thing, the popping out of the nipple areola complex has been managed by doing internal coagulation of the tissue. So friends, I am sharing this video. My English is not very good, I hope, but I hope you are all plastic surgeons. You must be able to you must know what I am talking about. And if this video is helpful to you, you can share with your friends. Thank you for watching. Namaskar.